Closed captioning for Lakeland Currents is supported by the Minnesota Department of Commerce, Telecommunications Access Minnesota, and Nisswa Tax Service. Nisswa Tax Service, tax preparation for Curious George is coming to Brainerd. Lakeland Public Television and the Brainerd Public Library are pleased to present a storybook fun day.
Chances are very good that you and I are going to die from heart disease. It is one of the most prominent diseases in America right now. Last year, about 910,000 Americans died from heart disease. It's estimated that another 70 million are carrying it, some of them who don't know that. So February is National Heart Awareness Month, and for this show tonight, we're going to focus on issues around heart disease, prevention, and symptoms and that sort of thing. And to get started with, we're going to start with Annie Cook, who is doing a little piece tonight on a brand new heart and vascular center that's just opened in St. Joseph's Hospital in Brainerd.
A healthy heart, something that will now be easier to get in the Brainerd Lakes area.
You know, we recognized there was a need in this community for cardiology services that could be provided right in town, and it's been our goal to do that, and we've been working on it for over 5 years.
More and more patients who come to this facility with acute and chronic heart problems who have requested, care here in the community.
The Heart and Vascular Center at St. Joseph's Medical Center will provide services that used to require a minimum of an hour drive to St. Cloud.
We will be able to add diagnostic services like angiograms and in selected cases, interventional services like stent placements to treat patients with coronary disease.
Though more full-time cardiologists will be brought on staff, the hospital is on its way to achieving its goals. This event was open to the public to come on in and see what the Vascular Center was all about. This initiative was community-based, so it's important for the hospital and the community to see what they've done together.
The promise that we made to the community was that we would improve access to care, that we would improve the coordination of care and the quality of care through an integrated system.
And in a month that celebrates heart health, this facility is a perfect complement. Annie Cook, Lakeland News.
My guests this evening are from Brainerd Lakes Health, which is part of the St. Joseph's Health Center in Brainerd. Dr. Vanessa Mangini is an internal medicine physician. Thank you for being here tonight.
Thanks.
And Patrick Ballantyne is a manager of the catheterization lab. And the catheterization lab, easy to say, isn't it?
It sounds scary, doesn't it?
It does, it does. Is part of the new center, isn't it? The new
is.
Heart and Vascular Center. And maybe we could start out talking a little bit about what this center is and what it's doing.
My primary focus in the center is interventional cardiology, and that's why I was brought on board about 9 months ago. And it was to set up an interventional cardiology lab. And it sounds scary, and actually if you're a layperson and you look at the lab from the outside, it kind of looks scary because there's a lot of equipment inside. What it allows us to do is take a good look at the inside of your heart, at your arteries, at your heart function. It allows us to the ability to put stents in to fix people with advanced artery disease. We put a whole new wing on the hospital, which is absolutely beautiful. The back side of the wing is the interventional cardiology suite. The front side is what we call CV diagnostics. We're doing stress testing, we're doing echoes, we're doing stress echoes. And then towards the center, we've got some new clinic areas.
Now this is a collaborative effort, isn't it?
It is.
Between not only St. Joseph's, but where else?
Well, we're very lucky to have a bunch of physicians that come up daily. The physicians are from Centricare in St. Cloud, and I've had the pleasure of working with almost everyone there in thousands of cases, and I've got personal experience that they do a beautiful job, good friends of mine, and I think we're very pleased to have them.
Now, there's some things you don't do there, though. I mean, you don't do bypass surgeries, do you?
No.
So could you sort of explain just the scope of what it is that you do and what things that you don't do where you might have to send someone else somewhere?
I can. It's kind of an open, kind of a subjective question. In a short period of time, I looked back at this probably 8 months ago, and I think, oh God, this is never going to open. It's taking forever. It seems like it's taking forever. And 8 months has passed, and we're doing cases already in our new lab. We're already doing intervention, angioplasty work, stenting work of the renal arteries, legs, peripheral is what we call that kind of work. What we'll eventually do is be a fully interventional cath lab. In other words, we'll be fixing people that come in to our emergency department, clutching their chest, doing the having the
That
big one,
sounds
as they
scary,
say.
too.
Well, what I like about this is for the community, up until now, at that point that they walk into the emergency department, we've had to fly them, or we've had to drive them to St. Cloud, or we've had to fly them or drive them to Minneapolis, whichever is the choice. And this could save a considerable amount of time.
And I know you do have helicopter service. I think you've had that for a long time. So anyone in the region now can be served quickly by this new facility, which is something that really, as you said before, you had to go to Fargo maybe, or St. Cloud, or Duluth.
Mm-hmm. And
now there's a place in central Minnesota that can start dealing with these kinds of issues. It's pretty nice to have that here.
it's very exciting, yes.
Dr. Vanessa Mangini, maybe you could tell us a little bit about what is heart disease, because as I mentioned earlier, it's a huge problem in this country, and one of the cardiologists on CNN was saying that it's a problem that most people don't really recognize or fear enough.
Yeah, that's true, Ray. Heart disease is kind of a broad category, but the medical term for it is coronary artery disease, or we call it CAD. And what that is a blockage or narrowing of the arteries that supply the blood to the heart. And this blockage or narrowing can be caused by a number of things, including a buildup of calcium, sometimes inflammation, cholesterol, which is a well-known risk factor for this, and even a type of blood cell called platelets.
And I know last week that President Clinton had another little reoccurrence because he has had 4-way or 5-way bypass surgery. And I was reading that it's not uncommon for someone who's had the heart disease that he does to have another blockage somewhere. So I think he had a stent or 2 put in. And they said this is not probably going to be the end of that. You'll probably have some more of those. So genetics also does play a role in this, doesn't it?
Absolutely. There's a lot of risk factors that we know about for heart disease, and probably even more that we don't know about yet. But some of them we can't control, such as being a male, like President Clinton, increasing age. As we get older, we increase our risk for heart disease, and things like family history are genetic factors. But there's also a lot of risk factors that we can control, and those are things like tobacco use and obesity. Obesity and physical inactivity or lack of exercise are, very common in the United States and really a treatable risk factor. There's also things like high blood pressure or hypertension, cholesterol, elevated cholesterol levels, and even things like diabetes and increased stress can increase your risk of heart disease.
It always amazes me that we identify these issues like smoking or chewing tobacco even has a risk, and it doesn't seem to deter some people, does it?
No.
Do you see them in the hospital all the time too?
We do. We see them in the clinic and the hospital all the time. And
isn't that amazing? I mean, that just amazes me when we have that information out there that you can do this to save your life or prolong your life, to live a healthier life. I have a friend who is a lung surgeon, and he said young people always say, well, it's not going to affect me until I'm older. He said they never see themselves carrying an oxygen tank up the steps the way I see my patients doing that sort of thing.
Right.
So it just really does amaze me. Do you think we're making progress in this fight against, I mean, we have been able to identify these risk factors. Are we making progress in our country, or are we sort of at a stalemate?
Well, it's probably a matter of opinion, and it depends on where you live in the country. There's some areas of the country that I think really are making progress towards, healthy goals, and there's been some initiatives in some cities to really take on tobacco and obesity and exercise, things that we can do personally to affect our longevity. So I hope we're making progress.
Does your hospital provide help, technical help, for people who are struggling with addiction, whether it be food addiction or tobacco addiction? Do you have people that can do the prevention side of it?
Well, we do have, through our pharmacy at Brainerd Medical Clinic, we have a pharmacy section who does provide tobacco cessation or quitting tobacco help, and there's a program through there. And they use different modalities. We can use things like patches, nicotine patches and gum, which are very commonly used. There's also little Nicotrol inhalers, which are another option. There's little lozenges and nicotine gums. So we try to get over the addictive part of the tobacco with the
Do
nicotine.
you find that people have to have some sort of tragic thing happen to them before they get serious about it?
I see that a lot. That's when it seems like, you know, people really say, I'm going to quit smoking now for sure. And often they do well for a while, you know, for a period of time after their heart attack or their stroke or their lung cancer diagnosis. And then, you know, as time passes and that tragic event, you know, gets further away, we see them go back to smoking in some cases, which, you know, is even more sad.
You have another risk factor is excessive alcohol use.
Yeah.
How does that impact the heart?
Well, actually, there's been some research on that, and it shows that moderate levels of alcohol actually are cardioprotective, where they actually help the heart because they increase the good cholesterol or the protective type of cholesterol called HDL. But after you move past that and you go to more excessive alcohol, it actually can be toxic to the heart.
So what would you define as moderate?
Well, usually we say no more than 1 or 2 drinks per day, not every day, but is probably a moderate amount. More than that, or binge drinking in excess is not good for the heart.
And is there a difference between, say, drinking beer or wine? Is there any difference of what might be more beneficial and what might not be?
Yeah, we think that there's some parts of wine that might be even better for you with the cardioprotective effect and the HDL, but it's not perfectly defined yet. So even drinking beer or hard liquor in small amounts seems to be okay.
I've seen these charts that suggest what we should weigh, and it seems like most of them are not really realistic. I mean, it seems like they're weights that most of us can't achieve. Are we raising those figures up a little higher because of the weight problem that we're getting in America, or are they still shooting for those lower figures and trying to get a way to get people down to those body mass indexes?
Yeah, I think that ideally we'd still shoot for those because long term I think that is what's best for us and for our health. But we are targeting lower and lower targets for other things like blood pressure. We used to say that blood pressures in the 140s over 90s might be okay, and then it was 130s over 80s, and now we're very aggressive. We try to get people's blood pressure down into the 120s over 70s. We're doing the same thing with cholesterol. The bad cholesterol, we're shooting for under 100 with the LDL type of cholesterol, and even lower down into the 70s or less when you have heart disease, diabetes, or some of the other risk factors. So I think we're finding that lower is better in most cases.
And for people who just can't get their cholesterol levels down, I know statin drugs are one of the common things. Are they being shown to be pretty safe to use over long periods of time?
In most people, statins are very safe to use. We always have to monitor the liver because that's how the statins are metabolized, and so it needs to be monitored, by a physician. And also we monitor, especially for muscle effects. It seems like muscle pain or joint pain, achiness is a common side effect of statins that we recognize. And other than that, statins are very well tolerated.
So what are some other things that people could do to start taking better care of their health, of their heart health, I should say?
Well, the American Heart Association recommends an ABC approach. So A stands for avoid tobacco, because tobacco products in any quantity are hard on our heart. B stands for be more active. We recommend 30 minutes of moderate intensity exercise, at least 5 days per week. And C is for choose good nutrition. Foods high or diets high in fruits and vegetables, low-fat dairy products, lean proteins and fish are very good for the heart. And then aside from that, controlling your other modifiable risk factors like keeping your blood pressure down, through diet and exercise and medication if you need to, as well as the diabetes and cholesterol too.
I know that it seems like a lot of people get their blood pressure under control, and then for some reason, a year or two down the road, they spike. Is that just sometimes normal and because of the change in the body, or what would cause those things if everything else is the same basically?
Yeah. Well, as we get older, in some cases, especially when you have genetic or a family history of high blood pressure, our blood vessels can get more stiff with time, and therefore then our blood pressure goes up. But also, if your blood pressure isn't perfectly controlled at those levels we talked about, you can have effects on the kidneys, which also help to regulate the blood pressure. And so if your kidneys aren't working quite right, that can also make your blood pressure go up after it's been controlled for a while.
And it really is a silent killer, isn't it? Because a lot of people don't feel high blood pressure. Strokes
That's
are
right.
certainly one of the side effects in addition to heart disease. I know I read in the paper yesterday that a young man in South Dakota, or Southwest State University, died from an aneurysm. And so it isn't always an old person's illness to have problems with our veins and arteries, is it? I mean, it can happen to a variety of ages.
It can happen in young people, and as an internist, I take care of adults with chronic medical problems, and so I see a lot of older people that are on many medications that have heart disease, but I take care of a surprising number of young people that have high blood pressure and high cholesterol and are of a healthy weight and exercise, and so there's a lot of genetic factors there too.
Does high cholesterol always mean heart disease?
No, because a high total cholesterol isn't necessarily bad. It has more to do with the ratio of the good to bad cholesterol. You can have a high total cholesterol, but if your HDL or your good cholesterol is high, you can have a very low risk of heart disease.
Interesting. Patrick, I know that in your lab, and I mean, maybe I should jump back to here, but both of you can maybe address this a little bit. What are some of the early signs of heart disease? What is it that people experience? And I also heard on the news that 50% of women today do not know the symptoms of a heart attack in a woman. I don't know if that's an accurate figure, but I thought that's really amazing. But what are some of the symptoms that people are going to experience? And I know this is talked about a lot, but yet I think it's always never talked about enough.
I did a talk on this last year, and I did a lot of research, but I also kind of looked back on 15,000 cases that I've done, and I tried to draw some similarities between men and women, and they can have different symptoms. I've had men come in with a toothache that were having a heart attack. I've had people come in with backaches that were having heart attacks. I've had people come in with the classical symptoms: crushing chest pain, pouring sweat, pale, throwing up, and everything in between. The one thing that I've seen consistent with female patients is they tend to come in later. They're more apt to sit at home. They're more like the younger males. The males in their 30s to mid-40s maybe. When they have this chest pain, they think, oh, it must be that beer and pizza I had last night. And they sit at home for a day. And then they come in the day later going, I just can't get my breath. And they're breathing really hard. And I see that same scenario with women oftentimes, is they want to tough it out. They're not the sick one, they're the caregiver. And so that element, I think, draws part of it. Another issue I thought when you were talking about obesity that I thought is interesting is I've had people in the lab that when we shoot their coronary arteries and see what kind of blood vessels are actually feeding their heart muscle, it's hard to imagine some of these people could walk across the room. And so it's not necessarily the obesity oftentimes, but it's the inactivity. And I know if this person would have walked for 5 minutes outside, they would have had chest pain. I know their vessels were that bad, but they're so inactive that they don't even feel the angina. And that's kind of leading into that question that you're asking, the signs or symptoms of an angina versus the signs or symptoms of a heart attack, because they're very similar, yet the two are very different. The angina means you have a tight blood vessel, and the blood vessels that feed in your heart muscle. When you have angina, that blood vessel isn't letting enough blood through, and your heart is basically starving from oxygen. It needs more blood, it needs more oxygen, and you develop chest pain because of that. When you have a heart attack, it's basically the same process. That blood vessel, instead of being tight and not having enough blood go through, it's usually completely closed or almost completely closed, and it's a thrombotic action. It's a clotting mechanism that causes it to close. Symptoms are very similar, but usually with a heart attack, the symptoms don't go away for days or for a couple of days if you sustain it. Typically, people will have rhythm disturbances. People will have chest pain, back pain, neck pain, shoulder pain, arm pain. Different with everybody. With angina, the key symptom or the key thing to remember is it almost always comes on with activity and it almost always goes away with rest. It's the repeatability of it. You know, I'll have patients come in and Mr. Johnson will say, you know, I walk out to the mailbox. Every time I get out to the mailbox, I have this darn pressure in my chest. I get back and the house, I sit down in my chair and it goes away. And that's just classic. I had a guy I used to live next to a few years back, and he was a big farmer, just a big husky guy, and red face and overweight. And he came up to me once when I was out on my dock, and he said, every time I go out to milk the cows, I throw up. And I get this horrible chest pain. He said, what do you think, doc? And I said, well, I'm not a doc, but I said, I think you need to go see somebody. You know, like, can I drive you now? So it's kind of interesting. It's one of those classical symptoms. It comes on and it goes away. It's angina.
How do you test for heart disease? What do you do?
Well, we do typically with someone with a first onset of a chest pain, maybe we'll let it go away. They'll wait for it to come back, or if it becomes more severe. We always ask that question in the emergency department. Okay, you've had this before, but why are you here today? What happened? What changed? They go, it wouldn't go away. Okay, and what that does is it kind of lights everyone up in the emergency department. Brainerd St. Joe's has fantastic nurses and docs down there. They all get right on task. They order 12 lead EKGs, which shows us the electrical activity going on in the heart. When someone has a blood vessel problem, an artery that's closed in the heart or narrowed, and it's causing chest pain, there's very significant changes that are consistent among all individuals. Whether it's inferior, it's anterior, it's lateral, it's apical, it's something that you can see the changes on your EKG. It's electrical impulse, electrical changes. The other thing that they're going to do in the emergency department is draw blood. They're going to check for things called troponins, things called CKMBs. It's enzymes that are released from the heart when the heart is damaged. And typically you're not going to see those elevate for 3 to 4 hours. So if the angina or the chest pain started an hour ago, they're going to be normal. The next thing that you're going to want to do is, if the 12 lead is positive, you're having a heart attack, is you give aspirin, you give beta blockers, you give some heparin. Most of what we give are things that affect your clotting, okay? And so we, of course, look at the patient and we ask the patient if they've had any recent bleeding problems, any recent surgeries, any blood in their stool, things like that. If they're negative for that, then we progress through the channels of getting them to a cath lab like we just developed at Brainerd St. Joe's. And we get them into the cath lab. We put a tube in their groin area. The only reason we use the groin area is it's a big vessel and it's easy to use. Most docs are trained to do these caths from the groin. Once we get a little tube in there, it's a lot like the IV that you stick in your arm. It's just a small little plastic thing. It stings a little bit when you put it in. I've never had one in, but hopefully I've heard enough yelps, like, that stings. We numb it up first. Once we get that little tube in, we throw catheters, or slide catheters up. They're all put up over a little J wire. The only reason it's a J wire is because it protects as it goes up the vessel. It doesn't catch on anything. So it's a very flexible, soft wire. We wrap that around the aortic arch up near the valve and engage the coronary arteries so we can take pictures of them very quickly. The whole procedure takes about 15 minutes to get pictures. And then we know exactly what's going on.
I know you've got a little a stint.
I do.
Here. Could you show people
I do. I'd love to
looks?
show that.
I shouldn't say a little one.
This
It's
is
probably
actually a very big one, and the only reason I brought this large of a one is because you can see it on TV.
So that's one of the things that Bill Clinton, for example, President Clinton would have had installed in his system. If installed is the right word. I'm not sure that's the right word. But
yeah, there's a lot of technology and there's a lot of studies out there that we follow. Everything in cardiology is done with studies, and if you don't follow studies, it seems it's almost difficult to prove why you're doing what you're doing. So we look at studies that thousands of people have been involved in. I think probably in the 90-95% range of people that get their arteries fixed are given stents. And a stent is usually a stainless steel product, goes in over the top of a balloon, and we get it in the right place. We dilate the balloon from the outside, and it's kind of like a scaffolding device, and it holds the artery open.
Wow.
Okay. The new thing that's come out lately, and not really lately, in the last few years, are what's called drug-eluting stents. And we now use probably 80% drug-eluting stents versus bare metal stents. So there's two different choices. And we're much more apt to use a drug-eluting stent, the smaller and the longer the blockages.
really, and is that for life?
Yes.
When you put it in there?
Yes.
So it's not likely to ever clog in that particular spot again.
Well, that's a good question. That is a good question. Bare metal stents Typically, historically, 25 to 30% restenosis rate. They do narrow.
Oh, they do.
Yeah, they do narrow. They're relatively predictable when they re-narrow, bare metal stents are, and that's one of the big things that we'll see coming out in studies, and we have seen coming out in studies the last couple of years. Drug-eluting stents, on the flip side, only restenose 5% or less of the time. The problem with the way they restenose is the thing, and they restenose more in a critical fashion. But all in all, they do restenose less.
What should someone do if they think they're having a heart attack?
If they think they should have it depends. What I recommend people do is call an ambulance.
Don't drive yourself.
You know, I've worked in EMS also many years, and I've had patients that were halfway to the hospital. And the interesting thing about a heart attack is someone can have a little bit of jaw pain, very tolerable. They'll stop for a McDonald's on the way in. They'll have a cigarette and maybe a beer, and they'll come into the ER.
Wow.
And they'll say, you know, yeah, it hurts, it's okay, but you know, I've got this little thing going on. The next person will have crushing chest pain, we'll get in the car, and we'll have a cardiac arrest. It's kind of like a box of chocolates. You never really know what's going to happen.
So you want the most skilled people with you at the
I
time.
sure would.
That's
You know, you want someone with a defibrillator, someone with some medicines that if this does happen, if your heart does go into a rhythm that's lethal or fatal and you're in an ambulance, you've got a real good chance of still making it to the hospital. If
Good
you're
advice.
not,
Good advice. I'd like to thank you both for being on the show. I hope that you have given some hints and ideas of what people can do to help prevent getting into the situation. I know you always appreciate customers, but you would appreciate it more if they take care of themselves and don't come to the hospital.
vertical positions.
That's
There you go.
right.
So thank you very much for being on the show. Appreciate
That's
it very
right.
you.
much.
It's a pleasure.
Again, February is National Heart Awareness Month, and that's why we're doing this program this evening. And if you get a chance, check out that new Heart and Vascular Center in the St. Joseph Hospital. It's very nice. Join me again on March 4th. We're going to be looking at large game predators, wolves, coyotes, bobcats, and yes, cougars. We have them in Minnesota. You've been watching Lakeland Currents, where we're talking about what you're talking about. I'm Ray Gildow. So long until next time.